And thank you so much, everyone, for being here. It's really, really great to be here to talk about this topic that, as Rohini mentioned, apparently is something that's been 2 years in the making. So I really hope that I can cover everything. As she said, it's a very, very broad topic, and I might just scratch the surface, and I know that there might be a lot of questions at the end, but I'll do my best to answer. But hopefully within the presentation, I've done a good enough job of covering everything that might be asked. So I thought I would just start with a little bit of about me. As you can probably hear from my accent, I am South African. I moved to the UK about almost 5 years now, and I have been following a plant-based diet for, it will be 8 years in December, which is very exciting. I think we're probably the only people that count how many years we've been vegan, but for 8 years in December. I qualified as a dietitian, and I followed a vegetarian diet around that time. And through my research and through watching some documentaries, I just thought, actually this vegan stuff has something about it. So let me give it a go. And I kind of never looked back. So I've just always followed this lifestyle, and it is something that I truly, truly believe in. And then I came to the UK, and something happened by chance. I fell into this mental health thing, which started as a part-time job in an inpatient CAMS unit, so children and mental health services, and then led into this more eating disorder role within the community. And that's kind of where I still find myself today, working in central London, as Rohini mentioned, in a children's hospital, full-time in the NHS, as well as doing my private practice on the side. And I've walked this journey of inpatient and community, and still to this day, I do a bit of both inpatients as well as outpatient work in feeding and eating disorders. So that's about me, but let's get on to the topic for tonight, because we have quite a lot to cover. So just about the learning objectives, by the end of this topic, by the end of this talk, I hope we can all understand the signs and symptoms of an evolving eating disorder. We should all be informed of the science surrounding plant-based diets and the connection of plant-based diets or veganism to eating disorders, and then understand the nutritional vulnerabilities of plant-based diets, in particular relation to eating disorders, and how to optimize the diet with suitable plant-based alternatives. And in order to cover these learning objectives, we'll be looking at these topics. So we will cover the different types of eating disorders, the signs and symptoms of the evolving eating disorders, the possible causes, what the science actually says, what has the research said, what has the research looked at in terms of veganism and eating disorders. We will again look at nutritional vulnerabilities, and then the practical management in recovery of eating disorders. So a good place to probably start is to think about, well, what exactly are eating disorders? Well, eating disorders are very, very complex mental illnesses that are experienced across all age ranges. A lot of the time, we probably, in news and media, we see them a lot in young adults, but in actual fact, eating disorders can start at a very, very young age and go a lot into a lot older population as well. They are extremely life-threatening illnesses that impact both physical and psychological developments in children. They are persistent abnormal eating behaviors that significantly impair health and psychosocial functioning. And I think that's really important to bear in mind. It's persistent abnormal eating behaviors. So something that doesn't just happen over a short period of time, but perhaps something that can go on for months and months and months, and sometimes months and months and months without actually being recognized. Eating disorder behaviors, they're often associated with depression, OCD, or other anxiety disorders. We often say in clinical practice, what else has and I'll say adolescent because that's where I work, but what else does the young person have going on with them? Do they have some perfectionist traits? Do they have OCD? Is there something else going on? Because we seldom see the eating disorder on its own. It usually is in connection with something else. It's really important to note that eating disorders are not white female disorders. And really sadly, in fact, actually, if you Google eating disorders and go into Google Images, what you'll often find is that the pictures are all white females. And it can be really, really difficult, because I think, and we'll talk more about this in a bit, but I think a lot of the time there are a lot of people that go underdiagnosed because of it being seen as a white female disorder. So let's look at the types of feeding and eating disorders. This is a very comprehensive list that is taken from the DSM-5. The DSM-5 was recently expanded to include some feeding disorders and not just focus only on eating disorders. So I will go through these very quickly, but I do recommend, if I don't cover them enough, there is a lot of information that you can go and research. But we'll cover the ones that are, I'll give a brief explanation of all of them, but we probably all know anorexia nervosa as one of the most popular eating disorders that are probably spoken about in media and everything. This is the restriction of energy, a very, very a high restriction of energy. It's often associated with a very low body weight. The patient or the person might have a very high preoccupation with shape and weight and what they look like. They have a very high intense fear of gaining weight. So the minute you start to talk about adjusting diets to gain weight, you will see that intense fear of gaining weight. So this is often associated with a really high inpatient population because of the fact of the poor weight gain that we often see in these patients. Then we get bulimia nervosa. This is recurrent episodes of binge eating. This is often seen in a very short period of time. There is some loss of control when this eating has happened. A patient will often say, I think I remember what I ate, but I'm not entirely sure, because it is this complete loss of control when they are eating all these foods. It's followed by compensatory behaviors. So whether that might be purging, so vomiting, exercise, laxative use, these are all behaviors that might be associated with post a binge in bulimia nervosa. Then we get binge eating disorder. So this too is associated with eating in extremely high amounts of foods in a very short space of time. Again, we see that loss of control. Except with binge eating disorder, we don't see those compensatory behaviors. We won't see that purging. We won't see the excessive exercise or perhaps the laxative use. Binge eating disorders, often you'll see when you see a patient, they might say, I ate a lot in a short period of time. There's a lot of shame, a lot of guilt, a lot of embarrassment associated with how much they eat. They often say they feel really full, but they keep eating. So again, this is a really, really severe eating disorder that, again, as people see, sometimes goes unrecognized. Then we get avoidant restricted food intake disorder. This is ARFID. This is a feeding disorder that's been recently added to the DSM-5. This is similar to anorexia. It's often a failure to meet energy needs or eating very little. However, it's not associated with the way the patient looks. They're not concerned about their shape or weight. It's more to do with the sensory profile of food. So they might not eat certain things because they don't like the way that it feels. A lot of the time in ARFID, we see patients that have some neurodevelopmental delays with them as well, or there might also be some failure to meet nutritional requirements, difficulties in gaining weight. The food impacts their psychosocial functioning. So there's quite a few things that goes into this diagnosis itself. Then we get our other specified feeding and eating disorders. These are often our atypical versions, so our atypical anorexia. Again, there's that preoccupation with shape and weight. However, people with atypical anorexia nervosa will often be in normal weight. So again, sometimes can be overlooked as that patient can't be anorexic because they're a normal weight. However, their behaviors of restriction, of body dysmorphia are very, very similar. Similarly, we have atypical bulimia nervosa, where there is that compensatory behavior after a binge, but perhaps not as often as would fit the criteria of bulimia nervosa. The same with binge eating disorder, that atypical binge eating disorder. There's also purging disorder that fits into this category. That is the absence of binge eating. So a patient just purges after just general meals. There isn't actually a binge. And then nighttime eating syndrome also falls under that. Then we get pica. Pica is the consumption of non-food items. That has to happen for a period of over a month before a patient can actually get that diagnosis. So again, that is probably also a feeding disorder. Rumination disorder. So this is repeated regurgitation of food for over a month. We're seeing a lot more of this actually, interestingly, in adolescent services, and a lot of the time it may be associated with anxiety, with stress, where a patient just eats and feels like they can't keep their food down, and in actual fact really struggles to keep food down and just tends to regurgitate food quite regularly, and fluids as well. Then we get our unspecified feeding or eating disorder. So sometimes a clinician may be struggling to make to give a specific feeding or eating disorder diagnosis, so might use this until they get a better picture, until they have a little bit more information, perhaps to actually give one specific diagnosis to a patient. And then the others are body dysmorphia and orthorexia nervosa. So body dysmorphia, of course, just having a distorted view of yourself, and then orthorexia nervosa, that extreme obsession with health and healthy eating and behavior, so perhaps exercise is involved a lot here as well. So that's just a very, very quick wrap over the different types of feeding and eating disorders that we might get. As I said, go look at the DSM-5 if you would like to know more information about that. But now that we know that, what exactly are the incidences of eating disorders across the UK? Well, according to BEAT, which is the eating disorder charity in the UK, about 1.25 million people suffer from eating disorders, which is really quite high. And this can vary across populations. So I've tried to get a little bit of a variety across age groups here, but we can see in 11 to 34-year-olds, it can be quite high in both females and males as well, with anorexia nervosa being quite high in females, but actually bulimia nervosa and otherwise specified eating disorders the highest. In a US study in 13 to 18-year-olds, it was showing that binge eating disorder is actually the highest of the eating disorders that exist. What we see in treatment, so this occurs in community settings as well as in inpatient units, we see a lot more anorexia, atypical anorexia, and actually ARFID as well, so that avoidant restricted food intake disorder being seen. And we can see actually that in treatment, we don't actually see binge eating disorder being seen a lot, but actually it is quite high in populations. So we can often see that binge eating disorder goes unrecognized and not treated, because it can often be seen as people just perhaps being more overweight and they've got an eating problem and they just need to lose weight without actually realizing the seriousness of the situation. And then I thought it would be good to have a look at what actually happened during COVID and post-COVID with eating disorders. And this is something that I worked in actually quite a lot during COVID in eating disorders, and I was definitely part of noticing this huge increase. But this was a recent 2022 study and done by Dasha Nichols, who's a consultant psychiatrist, and she looked across 70 children, young person eating disorder services across England. And generally, these are reports are recorded quarterly. And in 2016 and across the years, there's kind of been a stabilization of referrals around that number of 1,757. In March 2020, all of a sudden, there was this really, really high drop in referrals, and this fell by 25%. And this can probably be put to pandemic fears. We were going into this lockdown. People were perhaps leaving their homes in the UK, perhaps going to homes elsewhere. People were kind of scared of going to seek help or going to utilize the NHS because of the high pressures that the NHS was under. So there might be quite a lot of reasons for why all of a sudden those referrals dropped. Then what we saw in spring 2020 was all of a sudden this huge increase in referrals. And in fact, the amount of urgent referrals, so those patients that were perhaps more red when we were using the junior Marspan at that time, who were really, really high risk, being referred more. And this was when actually schools started to return. So perhaps a time where we saw more professionals being concerned about students or parents accessing help and realizing that actually perhaps their kids do have a problem, and maybe in adults as well when they went back to work. And now 2 years into the pandemic, we can see that in actual fact, there is a huge problem at the moment in CAMHS and eating disorder services with 5,491 referrals, with urgent referrals actually having tripled and routine referrals increasing by 85%. What's really interesting is that patients didn't really differ between age or gender, post the pandemic or pre-pandemic. And the most highest diagnosis during these periods were anorexia nervosa and ARFID. It's really important to say that COVID definitely had a massive impact on adolescent mental health, and not just in eating disorders, but across mental health in general. And I think in adult mental health services as well, we probably saw that. But what about eating disorders in relation to veganism? So this was a wonderful study done by Fuller, who did a flash study in 2018 to just have a look at how many patients who were known to eating disorder services were following a vegan diet. So we looked at both adults and adolescent populations. So in special eating disorder units, 11% in adults were following vegan diets, and in day services, we saw 6.4% following vegan diets. And then in children, young person services, we saw 16% who were patients admitted following vegan diets, and in day services, we saw 8.1% following vegan diets. So in the grand scheme of things, we would probably say there aren't that many people following vegan diets, but enough are. So what do we need to know about it, and how should we be able to treat it? But before we get onto that, what are eating disorders? Who gets eating disorders? Well, anyone can get an eating disorder. There are so many stereotypes, and as I mentioned earlier, so many people see it as this white female disorder, but that's a lot of the time when people are thinking of anorexia. But when we think about the broader term eating disorders and all the DSM-5 criteria that I've covered, we can probably see that anyone can get an eating disorder. It's so often seen as a female disorder, whereas it's really not. In males, it's quite often easy to mask it, that concern with leanness, how I look, that weight control, muscle building. It can be seen more as like, I want to look good, rather than actually this person could be suffering from some eating disorder tendencies. And actually in males, we do know that a quarter of males do suffer with eating disorders. People in larger bodies, there's that stigma associated with being weight. They can't have an eating disorder, they're too overweight. But we know that in actual fact, that can be a thing, whether it's binge eating disorder, whether it's perhaps an atypical anorexia nervosa type of diagnosis. It can definitely exist in those that might be overweight. There was an analysis done of a youth risk behavior survey where it looked at, where it found that actually lesbian, gay, and bisexual students have higher rates of unhealthy eating behaviors, as well as transgender youth who actually report that they have the highest rates of eating disorder diagnosis and compensatory eating disorder behaviors. And oftentimes these minority groups are the ones that are overlooked. And the reason for that, perhaps they feel like they have so much else more going on. They don't necessarily feel comfortable coming forward. There might be some misconceptions in healthcare as well about who gets eating disorders. So therefore, again, these people can't possibly get eating disorders when they've got so much else going on. We can overlook them. But in actual fact, it's not true. There are too many stereotypes associated with eating disorders. And we need to bear in mind that actually any one of us could have it. So I just want to say that for the remainder of the talk, I'll probably focus a little bit more on anorexia, because this is probably the thing that gets the most media when it comes to veganism. So I just want you to bear in mind as we go on from this point. So talking about the signs and symptoms, what do we need to look out for when we are thinking about a patient coming in who could potentially have an eating disorder, or perhaps someone in our families? Well, in evolving eating disorder can have many different phases. So there is not just one sign or symptoms. We might see loads of these all in conjunction, starting with one, leading into another. So probably the most important one is unexplained changes in weight, again, talking about anorexia. So we might see that rapid weight loss that can be associated with fainting, hypothermia, all of a sudden feeling cold all the time because of that weight loss. There's that restriction of diet, again, reported for reported health reasons. This is where we possibly get the most attention when a patient says they want to be a vegan or follow a plant-based diet. Because what it means, it's the removal of food groups, and that removal of food groups means removal of calories. So all of a sudden, it's a reported health reason, but it's more because it's restriction of calories that the patient is focusing on. We might see binge eating. So again, talking about binge eating disorder, we might get that obesity. That could be a reason, or perhaps bulimia nervosa as well. In females, there might be some menstrual irregularity, so the loss of a period for quite a number of months. That's something we look out for quite a lot in adolescents. But needs to fit within their population standards. Vomiting, so whether that's, it could be discrete vomiting, but just keeping a lookout for those things. Muscle weakness, Patients who have quite a lot of weight loss might all of a sudden experience quite high muscle weakness. Abdominal symptoms, that's a big one. There might be delayed gastric emptying, so constipation is reported a lot, bloating, the patient always feeling full, feeling uncomfortable, again, a sign, symptom of that. Changes in mood. This is a really important one, because this is probably one that parents will sometimes say to me the most, that they'll say, you know, my child is just so different. They're all of a sudden withdrawn completely, get irritated really easy, they're depressed, they're anxious. And we see this quite a lot in patients who, parents will often say that they don't find enjoyment in things anymore. They just don't seem happy. And I think that's really important, an important one to think about. If you see all of a sudden somebody who used to be so bubbly and cheerful, along with other signs, all of a sudden withdrawing, it's a really important thing to look out for. And actually a denial in that sense, on that note as well, that denial about anything. No, I just don't want to go because I don't want to go, but it's that denial about what's actually going on within them. And then excessive exercise as well is something that we might see as well, a child all of a sudden becoming very, very interested in exercise and perhaps doing quite a lot of it, and adults as well, young adults as well. Some other signs that we might see are things like hair loss, which is due to vitamin deficiencies. We might see blood abnormalities like anemia, dental erosion, perhaps from vomiting, low blood pressure, bradycardia, delayed puberty, osteopenia, so the early onset of osteoporosis. So there's quite a lot of things that we might look out for, but a lot of the time there will be that denial if the person is presented with any conversation around these things. So really important to bear that in mind as well. So what causes an eating disorder? Well, we know that a specific cause actually has not been established. As I said earlier, sometimes we look at it and we say, well, what else is going on for the child? Is there OCD? Is there perfectionism? And that is often a genetic predisposition, which can, again, be part of it. So perhaps they're growing up in a home where there might be some mental health complex mental health difficulties, and that might put them at a higher risk of developing an eating disorder. There might be emotional and cognitive vulnerabilities. So neurodiverse children, for example, might become more rigid, more fixated on healthy eating, or fixated on certain things or food rules. Might be hard to break them out of that. For adolescents, there might be lack of social acceptance, or even in adults, there's that perfectionism. A child who's been bullied perhaps might be more susceptible to an eating disorder. Someone who's struggling to relate to others around them, so emotionally might be struggling. Those are all risk factors potentially, and could be lead to potential causes of eating disorders. And then we have some social and environmental factors. So this could be pressure at home, pressure at school, that need to achieve almost, and what more do I need to control everything around me. Cultural beliefs about weight. So we know that a lot of the time different cultures have different beliefs about weight, which can play a huge part into eating disorders. Social media is a huge influencer, especially in the young population at the moment. We know TikTok is really rampant with videos that are just really not helpful in the sense, and unsupervised dieting as well within the social and environmental factors. There might be this tendency to diet within the home that can go unsupervised, and that can lead into more eating disorder cognitions. So what then is the link to veganism or plant-based diets in general when it comes to eating disorders? And I have a couple of theories about this, but obviously my theories aren't always helpful. It's more important to look at the science behind things, but we do often see a correlation between perhaps eating disorders and veganism. And there's this wonderful study when that looked at orthorexic eating behaviors and compared them to people following a vegetarian diet. So we know that with vegetarian diet, there might be a preoccupation with consuming meat-free foods or meat-free meals, and that's for ethical reasons. Whereas with orthorexia nervosa, there's that preoccupation with consuming healthy, pure foods, and that's actually for being healthy. And then we see the similarities between the two. Well, there's always specific food selections, making eating related issues an important area of someone's life. And you can probably all think of these points as I talk through them and relate them to veganism or following a plant-based diet, focusing on quality of food intake, the reduction of food intake according to specific nutrition rules, nutrition rules specifying which foods are allowed and which foods are forbidden, rigid rules, an inability to remain flexible in one's eating habits. So we can definitely see that there is that correlation between the two. But actually this study, what they found is that it looked at quite a wide variety of people following different types of vegetarian diets, but it found that those choosing to follow that diet for health reasons were at higher risk of developing an eating disorder, whereas those following it for more ethical reasons probably were not at such a high risk. But we can see why these rules might be associated. So when we think about eating disorders, they are centered around these strict and very rigid food rules. I can't eat that. And it's always about this calorie restriction. When we think about that in terms of veganism, it is often veganism is focusing on control of the food, what we can and we can't eat, but that's probably a lot of the time for ethical or health reasons. For a lot of people, this can advance into restrictive eating patterns. Someone with an eating disorder can often use vegetarianism or veganism as a mode of restriction to reduce calorie intake. It's more socially acceptable to follow a plant-based diet of any form. So any vegans, vegetarian, pescatarian, it's a lot easier to go out for dinner with friends and say, no, I don't eat that because I'm a vegetarian, as opposed to saying, I'm not eating that because I don't want to eat that many calories. So again, it's really important to know that. There's also very similar behavior in eating disorder patterns and in veganism in checking food labels. One might be checking food labels for any animal contaminants, whereas another might be checking food labels for calories. But again, when we are dealing with patients who where there is a higher risk of developing eating disorders, we really need to think about what exactly is the correlation between the veganism and the eating disorders. But let's look at the science, what the science is. In fact, there's very little empirical evidence between plant-based diets and eating disorders. A lot of the time, studies will focus more on vegetarianism. They don't always look at veganism in particular. As I said earlier, there is that correlation, and oftentimes that correlation is in relation to people who have anorexia and who are following plant-based diets, again, probably associated with that restriction of certain foods, cutting entire food groups out, reading labels. So there is that correlation between them. It is very important to say that pre-existing eating disorders, according to the science, are more associated with vegetarian diets. So always that, in fact, the pre-existing eating disorder was always there. And the vegetarian diet is perhaps used to maintain weight, therefore maintain the eating disorder, but the eating disorder symptoms always tend to come first. So answering that question, there's definitely that correlation, but eating disorders are not caused by following a vegan diet. So again, a lot of the time we probably get a lot of bad media about this topic, but hopefully I've made that very clear in these last few slides. So what is the role of the clinician then when it comes to talking to patients about eating disorders? Well, if they do want to follow that type of eating pattern where they want to be vegan or they want to follow a plant-based diet, we need to ask, is the choice of diet moral? Is it an ethical choice, or is it for shape and weight reasons? We have to respect individual choice and offer treatment based on this. We have to understand how to nourish a patient based on their dietary preference and work collaboratively with them. In life-saving circumstances, there has to be some flexibility, and I say that from an inpatient perspective, and that's because for some patients who may have to be nasogastric fed, there aren't actually even any vegan feeds on the market at the moment. So we do have to allow some flexibility in that sense. So I often say when I first meet a patient and they tell me this, I want to follow this diet for a certain reason, I often say to them, you need to be able to ask yourself this question: can I look after my health, and can I make the right decisions? Can I make the right food choices to nourish my body in the way that I need to? And that's a really important question to ask if they want to follow this vegan plant-based way of eating. There are some certain things to be conscious of, and I'm aware that I'm talking to a group of plant-based professionals where often we do promote this whole food plant-based diet, which is maybe oil-free, which may be no fats, very little sugars, etc. But following a whole food plant-based diet is actually not possible in recovery for anorexia. This is for multiple reasons. So the high fiber content, it can often mean gastric discomfort in a patient who's been restricting for a very long period of time. And then all of a sudden we want them to start eating whole foods. It can be really, really uncomfortable for them. Plant-based foods are naturally lower in calories. So again, we fall down that slippery slope of allowing low calories, maintaining an eating disorder. The reduction of oils is simply not possible in trying to make up those calories. The same with the use of plant-based meat alternatives, desserts, processed foods. And I'm fully aware that as a group, we do focus on health a lot, but in actual fact, in this patient cohort, in that recovery, unfortunately, that following that type of diet just isn't possible. In time, I always say to patients, we can have a look and we can adjust things and we can see how it goes. But initially, we do not want to maintain the eating disorder. What we want is that recovery to take place. And there's this wonderful quote that I came across in a podcast that I was listening to by Dr. Paul Conti. And he says, the greatest predictor of being able to help someone in therapy is the establishment of rapport. And I think that's so important because as clinicians, if we're going into someone and who strongly believes in following the vegan lifestyle or wants to follow this plant-based diet and we tell them no, we're not going to get that patient rapport with them, and we probably are not going to be very successful in our treatments. So I just always feel like we have to go in respecting patient choice. So thinking about the nutritional vulnerabilities of a plant-based diet, now I've listed quite a few things here, but it's really important to say that these things are not actually dissimilar to a lot of claims about vegan diets in the general population. Within the eating disorder population and those who want to stay on a plant-based diet, of course, when we are really focusing on weight gain, we have to consider these nutrients. Now, these nutritional vulnerabilities are often due to the nature of the restriction. So, of course, a patient who's only trying to eat 500 to 600, maybe maximum of 800 calories a day, we will see nutritional vulnerabilities, whether they're following a ketogenic diet, whether they're following a low carb is ketogenic, but all the different types of diets. So we do really need to acknowledge that. But that's just something that we do need to bear in mind. So we need to plan diets carefully around these things. Some other things we might see are electrolyte imbalances in patients with eating disorders. So we might see potassium, low potassium due to laxative misuse or self-induced vomiting, low sodium due to water loading. So a patient who's coming in to be weighed might have very low sodium because they've been drinking loads of water to gain weight. Calcium due to vitamin deficiencies or to phosphate treatment that they might be on. We might see low phosphate as well, which is secondary to starvation. And then we might see creatinine and urea imbalances due to severe malnutrition and low protein intake. So how can we optimize the diet when we're dealing with a patient who's following a vegan diet with an eating disorder? Usually in general practice, a refeeding meal plan would consist of 3 meals and 3 snacks. We choose foods that are high caloric density. We try to use energy-rich beverages over water. So that might mean juices rather than water, fruit juices over water, milk over water, those kind of things. We want to encourage substantial snacks. Serve dessert with at least 1 meal a day. In fact, these things would be exactly the same in any patient who's being refed in an outpatient setting. We would always do 3 meals. We would always use high calorie things, choose high calorie choices. We would always choose energy-rich beverages over water. So this isn't specific to veganism, but let's look at what a typical day would look like for an average patient. So we can see that across the day, we might use, we see that breakfast snack, lunch snack, dinner snack pattern of eating. It's all broken down into the specific food groups. So our certain quantities of carbohydrates to proteins to fats. And across this day, we see that it provides 2,500 calories, 95 grams of protein. But we can see the use of course, non-vegan or animal-based products. So that we have our milks, our yogurts, our tuna, things like that, desserts, etc. So how can we adjust it to make it a little bit more plant-based? Well, if we think about it, I've tried to do this in the best way that I possibly can, but by drawing comparison to the animal products. So when we think about milk, and this is all per 100 mils, when we look at the energy, the protein, and the calcium content of milk, nowadays it's just so easy to make it suitable to follow on a vegan diet. So there really is no reason why we should be telling patients that they can't do something. We can see that in actual fact, probably the ones that we might lean a little bit more toward would be your Alpro Soya Junior milk, your Alpro Soya protein milk, or your Mighty P protein milk. Those are the ones that I would usually tend to lean toward in practice. The Alpro Soya protein is actually quite hard to find unless you can order it online. So Alpro Soya Junior and your Mighty P protein oat milk tend to be the ones that I might use. We can see that the protein content might be slightly lower in the protein oat milk, but maybe we can make that up in other ways. So there are definitely ways that we can work around this. So when we look at yogurts, we see a similar thing. If we're looking at the calories and the protein and the calcium, that can be met actually with plant-based alternatives. So whether that's with your Alpro Greek style, which tends to be the one I lean toward mostly, otherwise the Oatly. I think a lot of people struggle with soya milk, which is why I feel like oat milk sometimes they tend to enjoy oat milk more, but sometimes it is lower in protein. So we do need to acknowledge that. But a lot of the time, Alpro Greek style yogurt is a perfect alternative, especially if we're using the oat milk and it might be slightly lower in protein. We make it up for the soya, or perhaps the Oatly Greek style. Again, calorie wise, we are absolutely meeting the calorie contents of the animal equivalent. So very, very good to use to show these. And I've done quite a lot of teachings and practice showing this chart to show that it actually is possible. And then if we look at our animal-based products and protein and our vegan alternatives, so we can see again across energy, quantity, energy, protein, again, we can quite easily meet it with vegan alternatives, whether it be with fake chicken pieces, tempeh, Beyond Burgers, vegan sandwich ham, tofu. The only one is cheese that might be a little bit difficult to meet with, and that's because of the protein content of the cheese. We do have to sometimes think about using something else instead of cheese, and then perhaps later on in the refeeding plan or in the weight maintenance plan or something like that, we can start to bring that in if the patient really wants to follow that, that pattern of eating. Now, in terms of the protein side of things, when we are talking about this, we tend to try and stay away from pulses and legumes. And the reason for that is because of the gastric discomfort that I spoke about earlier. So we don't want the patient to feel uncomfortable or to feel extra full, or and also to meet those calorie requirements. It is really important. A lot of patients ask me about falafels. Can't I have falafels? Again, it's that fiber content, it's the lower protein content as well. But I always say it can be introduced at a later stage, perhaps not right now. And then, of course, we have our desserts, and I think all of us know that in actual fact, vegan desserts there are so many more on the market now, and it's very, very easy to actually meet requirements based on in comparison to the non-vegan options. So again, very, very quite simple swaps that we can do to make the diet more vegan friendly for the patients. So if we go back to that initial example, you can see that I've done a few swap outs with the plant-based, well, with the vegan alternatives, and we can see that in actual fact, the calories are pretty much the same. I have rounded up the calories just to say it's not exactly 2,500, but the calories are the same, and in fact the protein is a little bit higher. So we always have that room to play with. So this would be a weight gain meal plan. It would be suitable for that, and over time we might reduce it to slowly go to like a weight maintenance plan once the patient has started to recover slowly. So going back to those nutritional vulnerabilities, we know that actually if a patient is at risk of low protein intake, actually the minute we increase calories, if we're eating enough calories, we'll meet our protein requirements. So a lot of the time, as soon as we start to do that, the patient is fine. With calcium, we meet that using the plant-based dairy alternatives. You see quite a lot of the calcium, a lot of non-dairy sources being used in a refeeding meal plan. That is because of the phosphates that we need to be careful of dropping too quickly in refeeding syndrome. So again, we use that quite a lot. Iron, we get that from the fortified cereals, nuts and seeds, vegan meat alternatives. Vitamin B12 and vitamin D, we often supplement with, and sometimes actually with the B vitamin as well. And this is standard practice no matter what diet the patient is following. Maybe not always B12, but I always say actually sometimes you're not going to do any harm by starting a patient on multivitamin supplements. And then our zinc and our iodine, tofu seeds, nut butters, oats, iodine, fortified plant-based milk. So we can meet those, but it's really important that actually the diets do need to be well planned. What happens in the UK, again, this is a really great study done by Fuller et al., who actually looked at the opinion of health professionals who work in eating disorder services and their opinions of veganism. And it was actually really comforting to show that they all had positive attitudes toward veganism. Now, the Human Rights Act of 98 means that actually we have to respect individual choice. So that means that a patient who's being admitted, we have to provide them with their choice because they have asked for it. That is their right to be a vegan, to follow a vegan lifestyle. So we do need to make sure that we respect patient choice. Oftentimes, there might be some defenses if the patient is extremely underweight and just cannot make the right decisions based on their health, because we know that obviously those who have eating disorders don't often have the best cognitive abilities to make decisions. So there might be some defenses. However, a special eating disorder unit has to have flexible catering, or it can be open to legal action. And I think that's really important to note. It is really important, again, to re-emphasize here that there is no vegan nasogastric tube at the moment. So in inpatient units, unfortunately, that is something that cannot be accommodated for if the patient has to be fed via nasogastric tube. So in summary, I'm sorry, I know that this has been a very long talk. There is that correlation between eating disorder and veganism, and often it's the behaviors that are associated that are very, very similar. So following a plant-based diet for someone with anorexia can be seen as a form of restriction as part of the pathology of the ED. So it's a way to maintain their eating disorder, not necessarily, it's not because of the veganism itself. Vegan diets do not cause eating disorders. There are limited studies on this topic. Sample sizes are often small. Different types of vegetarian diets are used in different studies. There's a lack of standardized questionnaires. So it is it is a topic that's probably open for a lot of discussion. A patient who comes into eating disorder services and wants to follow this type of diet just has to be comfortable using meat alternatives, and it is really hard. But again, it's about that establishment of rapport with the patients. Nutritional vulnerabilities do exist due to the restriction of the diet, the restrictive nature of the eating disorder, not necessarily due to the vegan diet. Again, very important to note that. But well-planned dietary patterns are definitely suitable in treatment. So making sure that we accommodate for the patient with suitable plant-based alternatives means that the patient can maintain their dietary choice whilst in those recovery phases. I just wanted to add a few resources in. A lot of them are related to adolescents, but the Beat Eating Disorders website is fantastic and has loads of information, as well as support groups, and it's a really, really informative website, and I absolutely refer loads of people onto it. And then just to include some of my references that I used to do this talk.